Good morning. Thank you IPDI providing me such opportunity. I am going to present on the topic thrombosuction in ST elevation MI is still in our practice. My case, she was 61-year-old female without non-comorbidities, presented with history of chest pain for 6 hour duration. At ER, her ECG showed ST elevation in anterior chest lead along with reciprocal changes in inferior chest lead. So we decided to take her to cath lab and we did coronary angiography. It showed proximal LAD is 100% occluded. Then BMW wire was crossed through the lesion. Then BMW wire is crossed through the lesion and pre-dilatation was performed with the balloon and with the pressure of 12 to 14 atm. And multiple episode of this ballooning was performed. And although the multiple episode of ballooning was performed, we could not get the flow. So we, and the patient had history of ongoing ischemia, so we decided to do thrombosuction in this case. And the thrombosuction catheter was placed and thrombosuction was performed. And
thank you. Thank you. Actually, I want to give my own comment on the previous lecture on multivessel PCI in the same setting or same hospital. See. Actually, all these guidelines comes from the Western data. But if you consider the scenario in our country and neighboring country, finance is one of the major constraints. So, multivessel PCI in the same hospital stay is cheaper than if you deferred it for the next session. So, if it is doable, I think it is preferable to do it in the first culprit, then the same hospital setting, maybe after 3 to 4 days. This is our usual practice to do multivessel PCI in acute myocardial infarction. I think it is also cost effective for the patient.
Thank you, sir. Thank you for valuable comments. Now I'd like to, still we are facing the technical glitch. Meanwhile, I invite Professor Afzal sir and Professor Jihad Khan sir for their brief comments on the previous sessions.
Thank you very much for inviting me. I want to add a few points that though primary PCI is ideal in every case, but we have serious limitations in our country. First of all, mind onset. Most of the people do not understand what is primary PCI. And when a patient comes and we advise for primary PCI, they have to explain what is primary PCI, and many do not agree for that. Second, when they agree, most of them do not have financial capability. Another problem for our country is especially for Dhaka, is traffic jam. You cannot reach from Tongi to a place in a very short time. It takes more than hours together to reach for a center. And another problem is most of our cath labs do not remain open round the clock. That is another problem. And I think there are many senior cardiologists, and at least we should plan that at least one cath lab should be open round the clock. In Western countries, there are always specialists who are running the cath lab for 24 hours. We should think it seriously also. Thank you.
Thank you. We'll be going back to our case.
Sorry for the inconvenience, and the video is not playing. So my conclusion is, although routine aspiration of thrombectomy before primary PCI is not useful, it is harmful. As the data came from the total trial, that showed it would be harmful in case of the primary PCI doing the thrombectomy. But in our case, those patients who have the high thrombotic burden along with the ongoing ischemia, it could be performed. It would be the 2B indication. So with this, I would like to conclude my session. I'd like to, my take-home message would be routine thrombosuction in primary PCI is not recommended. And thrombosuction in high thrombus burden with ongoing ischemia, it is still useful in primary PCI. Thank you.